Hi, I'm Dr. Bec Bennett, and you're tuning into the AIMER video series. AIMER is a practical, research-informed program designed to help hearing care professionals, like you and me, provide holistic care by supporting the social and emotional well-being of our clients. If this is your first time joining us, I highly recommend going back and starting with video number 1 so that you can follow through the series. If you've already watched the earlier videos, awesome, welcome back. It's great to have you here again. Today, we're diving into AIMER video number 2, Understanding the Gaps in Audiology Practice. Let's get started. If you're not currently talking with your clients about the social, emotional, or mental well-being impacts of hearing loss, or if you're unsure how to open up these conversations, or whether it's even part of your role, you're not alone. Many of us, myself included, have felt that quiet hesitation, that moment when a client says something deeply personal and we think, I want to help, but I'm not sure how. If this sounds familiar, then this video is for you. In this video, I'd like to take you through some of the key research findings, real-world data from clinicians just like you and me. To better understand what's happening in everyday audiology practice, we ran a national survey across Australia. We surveyed 94 hearing care professionals across the country using a 2-part study design. In part 1, clinicians responded to 3 case vignettes. 2 were older adults showing signs of depression, and 1 was an older adult experiencing grief after the recent loss of her husband. The cases weren't abstract, they were drawn directly from my own clinical experiences. Each vignette described the client's background, emotional state, and audiological details like hearing aid use and audiogram results. We worked closely with psychologists to ensure the symptoms in each case aligned with the DSM-5 criteria for depression, and that the grief case did not overlap with diagnosable depression. Case study 1 depicted a 92-year-old living in an aged care facility, withdrawn and hopeless, rarely using hearing aids, expressing deep fatigue, and said that life no longer felt worth living. Case 2 depicted a 67-year-old, recently widowed, interested in hearing aids but overwhelmed by grief, forgetful, and struggling with major life choices. Case 3 depicted a 68-year-old, retired and travelling, described perpetual exhaustion, social withdrawal, and low self-worth. Clinicians in our survey were asked, if this person walked into your clinic, what would your hearing care services look like for them? What would normal look like? In the second part of the survey, we used a more traditional survey questioning where we explored clinicians' knowledge of mental health, their perceived barriers to providing mental health support, and what factors influenced their decision to refer clients when they identified these mental health issues. What we learned was quite interesting. We recruited quite a diverse sample. We had participants from every state and territory across Australia, from new graduates to clinicians with over 30 years of experience. They worked across the full spectrum of audiology, including adult rehab, pediatrics, cochlear implants, tinnitus, vestibular diagnostics. It gave us a rich, honest snapshot of current practice. So first, let's take a closer look at how clinicians responded to the vignettes. Each case was presented individually, and we asked clinicians to describe their typical response, their usual care for this type of client. Now, of course, everyone described how they would manage the audiological issues. That's our bread and butter. But what we were really looking for was whether they also addressed the social, emotional, and mental well-being concerns raised by clients. Here's what we found. For case 1, depression, 61% of hearing care professionals included some reference to supporting the client's emotional well-being. For case 2, grief, 56% did the same. For case 3, depression, 46% described support beyond hearing care. So overall, just over half of respondents included reference to emotional or mental well-being support in their response. Those who did usually described light touch approaches, asking a few extra questions, gently checking in on how the client was feeling, or referring them to their GP. But none of the responses from any of the participants reflected a structured or comprehensive psychosocial support plan. So let's pause and ask a deeper question. Let's take a deep dive into the kinds of activities that our clinicians described when they were providing psychosocial support. So the clinicians who described more than just evaluating or supporting the hearing loss described things like being fully present, showing genuine care, listening without rushing to fix, asking curious or open questions, expressing empathy, building rapport over time, offering warmth, humour and kindness. These may seem simple, but they're powerful. If a client has ever said, "I feel better just talking to you," then you've already offered meaningful support. And that's the foundation of good psychosocial care. But scattered through these responses were comments like, "It would be nice to feel more equipped to handle these clients." Here's a couple of quotes from some of the hearing care professionals in our survey. One said, "I think it's an essential part of our role, but we're not trained for it." Another said, "There should be more offered through CPD on how to support clients' holistic needs." And a third said, "Sometimes I feel limited, like I can't go any deeper than a hearing solution." Have you ever felt stuck like this? The intent is there, the heart is there, the desire to help these clients was there, but confidence and clarity, that's where clinicians were falling short. If you've ever felt that way, know that you're not alone. Clinicians described using strategies like recognizing or validating the client's emotions, normalizing their experience, and checking in to see whether clients had support from family, friends, or their general practitioner or physician. Some went a little further. Some talked about social withdrawal and isolation, or they shared success stories of their other clients who had made it through difficult times like theirs. Some even described applying simple therapeutic techniques like counselling skills, solution-focused strategies, or CBT-style reframing, cognitive behavioural therapy. Now, these aren't necessarily advanced interventions, they're everyday skills that clinicians are already drawing on. Okay, so let's take a look at the short knowledge-based section. We used the Knowledge of Late Life Depression scale to assess how well hearing care professionals could identify the signs and symptoms of depression in older adults. This tool presents 10 statements covering common symptoms, myths, and facts, and asks clinicians to determine which are true and which are false. On average, participants in our study scored 29.4. For context, aged care nurses in other studies have scored between 28 and 32. So overall, our audiologists performed reasonably well. They seem to have good knowledge and understanding of symptoms of depression and how they might present in older adults. But there was still some inconsistency. Not all knowledge seems to be translating into confident clinical action. The key insight here is that it appears we have the knowledge base, but turning that into practice is still a challenge for us. So we asked clinicians, what's getting in the way of offering holistic support? And here's what they said. Many felt underskilled or lacked formal training. They worried about getting in over their heads and were unsure how to safely support their clients' emotional needs. Lots talked about time pressure or caseload demands, and many felt they had to provide or prioritise hearing aid provision. Some clinicians pointed out a lack of supervision or mentoring in psychosocial care as being a real barrier for them. And alarmingly, about 30% said that they believed that supporting mental and emotional well-being wasn't part of their scope of practice. This is despite national guidelines, including Audiology Australia, ASHA, the British Association of Audiology, clearly stating that psychosocial support is within our scope of practice. A couple of years after our Australian study, Professor Gabby Saunders and her team at the University of Manchester ran a similar survey with UK-based hearing care professionals. And what did they find? Virtually the same as us. Almost identical barriers. Top barriers included lack of supervision and mentoring, feeling underskilled, time and workload pressures, and uncertainty about how to help without overstepping. Let's now hone in on a crucial part of the clinician's role, referral. As hearing care professionals, we're not trained to provide psychological intervention. And so when we recognise that a client is facing significant emotional or mental wellbeing challenges, referring them to the right support is essential. So we analyse the vignette responses to see how often clinicians describe referral as part of their usual care. Here's what we found. For case study 1, depression, 53% described they would refer the client for further support, often to their GP, a mental health practitioner, or one of the nurses at the aged care facility. For case study 2, grief, only 14% mentioned referral. And for case study 3, depression, just 27 indicated that they would refer. Now, I do wonder whether convenience played a role in this. For case study 1, 53% referred or indicated that they would refer the client, but there was an element of convenience because the client was in a nursing care environment where there was a visiting GP or nursing staff on hand. So that may have played a role in the higher response we see there. But that doesn't mean that we can't also find avenues to support and refer our clients if they're living in community, living independently. So these initial numbers reflect what clinicians described unprompted. Further down in the survey, we asked more directly. We asked clinicians, if this client walked into your clinic, would you refer them for additional support? And this time, the numbers jumped. The vast majority said yes. So what's the takeaway? Well, clinicians do recognise the importance of referral, but it's not yet a consistent part of routine care. And further research confirms that referrals aren't happening as often as they should, even when clinicians want them to. So what's getting in the way? Well, clinicians told us that they're not sure who to refer to. They're not sure when to make a referral, what symptoms are bad enough. Some said they don't know how to refer. They're not sure of the process or funding options. Others said that they lack relationships with mental health professionals, so they wouldn't want to refer a client to a professional that they didn't know and trust. Some noted that clients decline referrals or that mental health practitioners lack experience with hearing loss, and so they weren't sure whether there was any real benefit to referring anyway. So even when distress is recognised, referrals often stall. In this study, one of the hearing care professionals commented, "I have a solution for hearing, but then they go, 'This is how I feel,' and my toolbox is empty." Have you ever felt like this? What you're feeling isn't failure. It's a system-level gap, one that hasn't caught up with the full human experience of hearing loss. So we also ask clinicians, do you believe understanding your client's mental well-being would affect your care or their outcomes? 75% said yes, 24% were unsure, and just 1% said no. So hearing care professionals described benefits like deeper insight into client needs, more personalised care, use of interdisciplinary services, and better outcomes that we treat the whole person. But it's not just our clients who benefit when we provide holistic hearing care. When we're unable to fully meet our clients' needs, we feel it too. We can feel disconnected from our work. One of our clinicians said, When our clients say things like, everyone's passed away and I don't have a social circle, I don't know how to help, I feel so out of my depth, like I'm failing them. You know, we don't have to have all the answers. We just need to know where to start and feel confident walking alongside our clients. The desire to support is strong. In Australia, 98% of clinicians in our study said they wanted more training on how to deliver better emotional support to their clients. And in the UK, researchers found the same. Almost all respondents wanted more training. When clinicians feel supported, clients feel heard, and outcomes improve. So let's reframe our role. We can do this using the no wrong door approach. Have you heard of this before? It means that you don't need to be the final solution, but you can be the starting point. We're not here to fix everything. We're here to listen, validate, and guide. We're not just a hearing care professional. We're often the first person someone opens up to about how their hearing loss might be impacting on other aspects of their life. And that makes our role incredibly powerful. The no wrong door approach suggests that a client can access the help they need through any door in the healthcare system. Even if we're the first door they knock on, we're not the last door if we can't help them. It's our role to understand their needs and connect them to the help that they're looking for. And that's why we developed the AIMER program. The AIMER program is practical, flexible, and evidence-based. It helps you recognize the signs of distress, respond with confidence, work within your scope, make your clinical conversations more human. It isn't about adding more to your day. It's about making what you already do even more meaningful. So let's take a moment. What stood out to you in this video? What did it help you to notice about your current approach or mindset? Open your workbook and jot down one small change you feel ready to make and 3 actions you could take to move towards that change. Remember, progress, not perfection. Even one small shift can unlock deeper connection and more compassionate care. You've already taken the first step just by watching this video. Now, what's your next step? Thanks for joining me today on AIMER video number 2, Understanding Gaps in Audiological Practice. In our next video, video number 3, we're going to explore the AIMER framework itself, what it stands for, how it works, and how you can begin using it in your own clinic. Remember, you're not alone on this journey. Together, we're building a future where connection isn't a bonus, it's the foundation. I'll see you in the next video.